So we're going to start off with where the thromboembolism comes from, and that is the deep vein thrombosis. Can't get away from it. Here's our guy, skinny arms, single skinny leg, but then the problem. He's got a big old swollen edematous foot and ankle. Now, if you've seen our videos on the approach to fluid where fluid shouldn't be, the approach to edema, you know that if you have a unilateral swelling, it has to be hydrostatic, especially if it's from one point all the way down to the ground. So you can run through the list: clots, cancers, cuts, compressions, but you know the problem is located somewhere in the deep veins or lymphatics of that leg. A DVT, the classic presentation, is going to be a 2 centimeter difference side to side. It's best to measure at the tibial tuberosity. Even femoral and popliteal clots will show a calf swelling. But if you can't, because the edema comes up higher, that's okay. Now, most people don't have a paper tape measure thing they carry around with them. So what you can do instead is actually just take your middle fingers and put them behind their leg at the same point and see where your thumbs touch. If on one leg you can cross your thumbs and the other leg you can't, that's a good indication that their circumference is different. Just make sure you do it at the same side. Obviously, the utility of this test gets less with more rugged tools, but you get an idea. Unilateral swelling one side to the other, that's probably going to be a DVT. If you know that you think you have a DVT, then what you should do is get a DVT Doppler. The key here is that it's a Doppler study, it's a vascular study, not a radiologic study. So make sure you order the Doppler or the vascular ultrasound. The things that don't help are Hohmann's sign. That has a likelihood ratio of 1. If you find Hohmann's sign, it is as likely that you don't have a DVT than if you do. It also has a negative likelihood ratio of 1. If you don't find Hohmann's sign, it is as likely the person does have a DVT. Palpable cords, calf tenderness. The only test you should be doing is this. And if you have your own bedside ultrasound, you can easily do a compression test on the femoral vein and popliteal. Just push on it and the vein should disappear, and then do a Doppler study. Point it towards their foot and see if the thing changes color. If it doesn't, you probably have a clot there. You shouldn't be the one to make the diagnosis for the radiologist, but that's a bedside test you can do in a couple of minutes, and you can do both legs yourself. If you find a DVT, you're going to treat it with heparin. And the heparin is then bridged to warfarin. You bridge, of course, because heparin has 2, 7, 9, and 10 and protein CNS. CNS have shorter half-lives. So if you start warfarin without the heparin, you're going to lose the CNS, the actual anticoagulant factors, and all that will be left behind are the procoagulants, which will make things worse. And this is the pathogenesis I really wanted to talk about. You have a blood vessel, and on it is attached the DVT. There's a portion of that DVT, the inside core, which is smooth-edged, stable, chronic. And then there's the acute DVT, spiky pattern all over it. It is the acute spiky DVT, the unstable portions that can dislodge and embolize. It is also the spiky edges that are more likely to extend the clot. The idea is that you've got this bad hedgehog spiky stuff, which can both embolize and extend. And so if it embolizes the piece that's good at extending. That's not great. What you do with the heparin initially, yes, it's going to help with platelet-derived mediators and make the lungs better if it's a PE. But what you're really doing is stabilizing the clot. The initial dose of heparin makes the unstable clot more like the stable clot. And as long as you maintain an anticoagulation, the clot will remain stable, and stable means not spiky. Stable means won't embolize, and stable means won't extend. So if you put them on warfarin without the heparin, the procoagulant factors will rise, and you're just going to make more clot. Now you probably have heard that you can use something other than warfarin. That is the non-vitamin K oral anticoagulants. The problem with that is that some people say you don't have to give heparin. I don't like that because I know heparin stabilizes the clot and helps with platelet-derived mediators. It turns out that this might work, but what I want you, the intern, to hear is if you find a DVT, start heparin. and then you can choose between warfarin bridge or NOACs. The reason why that is, and I'm going to take a cross-section of this and have it look right at us. This is the other edge of the endothelium. This is the endothelium. So this is the stable clot, and this is the now stable clot. This is the lumen that blood is flowing through currently. What our body is going to naturally do is this. It's going to punch holes in that stable DVT. Not only does a stable DVT not extend and not embolize, it also allows the endogenous system to open up pathways through it. Heparin does not dissolve the clot. Our bodies don't even dissolve the clot. Our bodies will poke holes in it to restore blood flow. But that can only happen if the clot is stable. This is the same thing that happens in pulmonary embolism. So this is enough pathogenesis of the entire disease, all talked about in the form of DVT. So a DVT that pops off and floats up to the chest is going to get there, right? The deep veins, especially the femoral, doesn't have any valves, and veins only get bigger as it comes to the heart. So if it embolizes, it only has one place to go, and that's the RV. And from the RV into the lungs, the vessels only get smaller, so eventually it's going to get stuck in the lungs.